Okay, so welcome everyone again. We've just started recording. My name is Allison. I'm the Associate Director of Social Work at the Penn Memory Center. I'm so excited to welcome all of you here today to hear from one of my favorite people. I've learned so much from her, Rachel Wiley of Day by Day Home Therapy. Rachel is an occupational therapist and the owner and founder of Day by Day Home Therapy. Rachel is certified in skills to care for caregivers of individuals with dementia and is a certified dementia practitioner. Rachel's also a certified master trainer of skills to care through Jefferson University Elder Care, and she trains occupational therapists from all around the country in the Skills to Care program. She's currently an advisory council member for Dementia Society of America. So, without much more ado, that's the short version of Rachel's bio. She's done a ton more than that, but I'd like to hand it over to Rachel to start us off.
Thank you so much, Allison, and thank you all for being here with us today. I'm very excited to talk to you about managing behavioral symptoms of dementia. I know this is something that so many of you experience, so hopefully we can give you some concrete strategies that you feel like you can leave here today with some new ideas for how to help you. Allison, thank you for the introduction. I also usually like to let people know that I do have some family experience with dementia as well. So that's why these lovely ladies are on my title slide. So my small practice is called Day by Day Home Therapy. And that is because my grandmother, who is on the left with my mom, her maiden name was Day. And these are her two sisters. In the middle is my great aunt Doris Day. And on the far right is my great aunt Jerry Day. All three of them passed away with dementia. And my mom was a primary caregiver for my grandmother at one point, and especially my aunt Doris in the middle. So we do understand firsthand what challenges can come up with dementia and what some of those behaviors look like. So just want you all to know I understand this from a professional and personal end. Okay. Sorry, one little tech issue. I'm just gonna, there we go. Actually, sorry, Allison, there we go. Just had to close a box that was popping up. Okay, here we go. So first thing I'd like to ask all of you, and this is a good time for us to practice using the chat. I'd love to hear from you. What do you all hope to learn today? So go ahead and start firing away. Send us some input in the chat so I can hear from you what you hope to take away from today. And then anytime there is any input, Allison, feel free to share any of that with me.
Okay, so far we've got a few. One is how to preserve available memory and dignity.
Okay.
Great.
Yes, absolutely. How to preserve available memory and capability. Dignity. Wonderful. Thank you.
Okay, we have someone saying improve my memory.
Improve your memory. Okay.
How to respond to a person with dementia. We might need to get a little bit more specific there because Rachel will definitely touch on that from a number of different perspectives.
Absolutely. Thank you, Allison. That's great. So how to respond to people with dementia. We can definitely talk about that in a general sense, and I'm happy to talk about that in a specific way as well if we get any more information. Okay, great. Any other input? Otherwise,
that's about it so far. So this is like a last call for what do you hope to learn today? Yeah. So how to understand some, okay, we have a few more. How to understand some bewildering behaviors and moods.
Okay, that's good. How to understand bewildering behaviors and moods. Okay.
Sounds like behaviors we might not understand, sort of in our version of reality. How to address denial on both my mom's and dad's part.
Oh, that's a good one. Yeah.
I'm going to read two more. Strategies for dealing with resistance to bathing and self-care. And then also resistance to sharing with me, her daughter, physical problems.
Absolutely.
And
Okay.
related, actually, how to work with someone who refuses personal care or is resistant to help during toileting specifically.
Great, great, great questions, everyone. I really appreciate all of your input. These are fantastic questions, fantastic input that you've all shared. I'm going to do my very best to try to address as many of these as I can. Of course, if you feel like I haven't addressed your question throughout the presentation, please feel free to, put it in the chat box again. And then that way at the end of the presentation, when we have some extra time, I'll do my best to address as many additional questions as possible. We are definitely going to touch on resistance today because I know that that's a really, really common challenge that people experience. So hopefully those of you who have concerns with that will feel like you have some concrete strategies to walk away with. Okay, thanks for your help, Allison.
Sure. Let me just let you know, we're also getting a lot of questions about driving, cars. So just want to throw
Great
that
to
in
know. Okay, thank you. That's really good to know as well. Driving is another really common and very tricky situation. So I appreciate you all sharing that. Again, while I may not have a specific slide on driving here, I am more than happy to talk about some of that with all of you today. Okay, so a few of the objectives I have here are really pretty broad. So, we want to make sure that we're understanding the causes, or sometimes you'll hear triggers of some of these behavioral symptoms and challenges. We're going to use the Triadic Model to do that, which is my favorite model. We're also going to discuss or discover approaches and how to handle or manage some of these challenges. And then we'll talk about strategies. So this wouldn't be helpful if we didn't talk about how to handle it once they come up. So we are going to talk about specific strategies to help you. Okay. So we're going to use the chat box again. I want you to think about any challenging behavior you've experienced. So go ahead and just put in the chat box a challenging behavior. So some of you have already given some great examples. So resistance to help during self-care, resistance to help during toileting, bathing, dressing, challenges with driving. These can all be potentially challenging behaviors. Somebody also mentioned, I think they referred to it as like bewildering behaviors. Sometimes we might refer to that as something like a delusion, a hallucination, a distressing belief. Does anyone else have anything to share, Allison?
Okay, so far we have unwillingness to acknowledge a diagnosis.
Mm-hmm.
We have swearing, like rude swearing at facility staff, maybe at skilled nursing, someone who won't agree to go in to be evaluated or diagnosed.
Yeah. These are really, really good points. So I think, again, some really wonderful examples. I think that it's exceptionally challenging when especially newly diagnosed, I think a lot of us have this expectation that our family member will acknowledge what's happening, right? And knowing that as the brain is impaired, it's actually impairing part of the brain that allows us to have insight, right? So they can't know that they can't know, they can't remember that they can't remember. So I completely understand how challenging that is. And again, we'll do our best to talk about some different communication strategies, in addition to some ways to adapt tasks, activities, and the environment that will help support your family members. All right, thank you, Allison. Okay, and again, I'm sorry, I have another box that popped up, so I just have to come back out for a second, and there we go. Okay, all right, so again, there we go. Okay, I have a list of various behaviors that we see in my practice very often. It's not to say if the one that you suggested isn't on the list that it's not a behavior. There's many more than what's here, but these are some of the most common challenging behaviors that we see with clients with dementia. So things like agitation, verbal and physical aggression, repeating. You can see over on the right, resistance to care, that's a really big one. Resisting bathing, resisting taking medications. All of these things listed here are possible challenging behaviors. Okay. So I like to kind of define a behavior first before we get into why this is important, because it's helpful to understand and be able to define the behavior to figure out A, why it's happening, and B, how are we going to handle it. And this topic is important because typically caregivers report that challenging behaviors are one of the most challenging aspects of care. They're often a reason for nursing home placement and can create a significant level of caregiver burden and can lead to caregiver depression and burnout. And, we really don't have a lot of formal training out there on how to handle these things. I usually tell people, even though I'm an occupational therapist, we didn't have a ton of classes on exactly how to handle these types of challenges. So this is really something that we lack in multiple areas of our society in terms of how to appropriately and strategically address these challenges. Okay, approaches to care. I just touch on this very briefly, just to let you know that there are a few different types of approaches to care. So we have a rehabilitation approach versus a habilitation approach. And this is most appropriate when we have a conversation about, things like occupational and physical therapy, even speech therapy. A traditional model, most of my fellow therapists will take more of a rehabilitation model when working with clients. This is when we're really trying to restore function. But what we know with clients with dementia is that restoring function is not the most realistic or achievable goal, but really what we can try to do is maximize current function. So we typically want to work with both the person with dementia and the care partner, because that dyad, that combination of the two people, that's really what's going to allow the person with dementia to function at their best possible potential. Okay. And then we have pharmacologic versus a non-pharmacologic approach. This is really saying, are we going to treat this with medicine, or are we going to treat it with something other than medicine? And a little bit more about that. I am not anti-medicine by any means, but I am a big advocate for trying some other strategies first. So not all behaviors have a pharmacologic approach to address it. Things like shadowing the caregiver or following them around, or repeating questions, or even wandering. We can't necessarily treat those behaviors with a medication. So it's important for us to consider what other approaches are available to us to address some of these symptoms. Okay, so now on to the fun part, the detective work. We are going to try to figure out, why do behaviors occur? So if you've ever seen a presentation from me before, I spend quite a bit of time on trying to figure out why behaviors occur, because I feel very strongly that if we can understand the why, then we can be more effective in the strategies that we develop. So I have one rule when we do this. I like to say you can't answer because of dementia. And my reason for that is that not every single person with dementia has behaviors. Not every single person who has behaviors has the same type of behavior. So we really want to look beyond that, right? We want to look beyond dementia and figure out what else is contributing to this behavior. All right. So any questions I should address before I dive into this, Allison? Okay, we're good. Okay, thank you. All right, everyone. So I am going to ask you, if you are sitting at a desk, or you have your computer, you have a piece of paper in front of you, if you could draw this model, that would be great. So I'm going to ask you to try to do some activities while we're working today. So I want you to draw, whether it's a triangle or a circle, I want you to put the word behavior with a space in the middle. I want you to have a block for person with dementia at the top, and then 2 other blocks or bubbles for caregiver and environment. Because I want you to try to brainstorm with me as we go. So again, this is called the Triadic Model. It was developed by Dr. Lar Gitlin and Mary Corcoran, I believe. I hope I'm pronouncing her name correctly. They are researchers who looked at, how can we determine what the causes of behavior are? Again, what are the triggers? So we have these 3 categories of triggers. We're going to try to figure out what's happening within the person with dementia. What is the caregiver doing or saying, or maybe not doing or not saying? And then what's going on in the environment? And we want to know what's going on in all 3 of these that's contributing to behavior. So I'm going to give some examples here. Okay. So when we think about triggers or causes of behavior that are taking place within the person with dementia, we think about a variety of things. We think about their emotional state, their physical state. And so we can think about things like sense of loss of control. I underline this one because this comes up very often when it comes to resistance. So we really want to make sure that we're putting a little star on that one when we try to brainstorm what our triggers are for any type of resistance. So a sense of loss of control. I think about this like, if I were to think about what it's like to have dementia, and all of these different parts of my life, people are now helping me with. First, it's the really complex things. So first, someone maybe takes over my finances and then handles my medication. And then I can't drive, or maybe that's the first to go, and all of these things are kind of taken over. I start to feel like I'm losing control. And that sense of loss of control can trigger a behavioral response. So I hope that makes sense in what I mean by a sense of loss of control. Other things going on within the person with dementia that could cause or trigger behavior include fear, fatigue or being tired, being bored, being confused, under or overstimulated, hungry or thirsty, and need to use the toilet. Sometimes you'll hear phrases like an unmet need. And that's really kind of this category. So an unmet need of being hungry and not being able to express that, or needing to use the bathroom and not being able to express that, that can actually trigger a behavior. Other things to consider going on within the person with dementia include things like arthritis, COPD, cardiovascular disease. These are medical concerns that we really can't modify. But there are also medical concerns that can be modified. So let's say they have pain due to their arthritis. That's something that can be addressed. Maybe there are side effects from medication. Again, that can be addressed. A medical condition that often triggers an acute or short-term change in behavior is a UTI, or urinary tract infection. And this is for anyone who's experienced this with their family member, a UTI in clients with dementia often triggers a pretty significant change in behavior, again, in a short period of time. Other triggers of behavior happening within the person with dementia include things like depression, anxiety, and I have here even dehydration. So again, this is not an all-inclusive list. It's just an example of some things that could be going on within the person with dementia that can trigger behavior. I'm going to give you specific examples of all of these shortly. We're just giving you some groundwork here. All right, so now we want to think about the triggers or the causes of behavior that are happening within the caregiver. So the caregiver may have a management style that triggers behavior. And again, there's no shame, judgment, blame from my end whatsoever. But we do want to be aware of how our actions as caregivers or care partners can trigger behavior. So, for example, expecting the person with dementia to do more than they're actually capable of can oftentimes set the person up for things like agitation, anxiety, restlessness, those types of behaviors. Other things like maybe not breaking down the task, maybe rushing the person with dementia, or not having some structure or routine could also be factors that trigger behavior. Also, caregiver stress. we know that that can impact our tone of voice, our body language, and those types of things have a very significant impact on the person with dementia. A few other communication triggers, I shouldn't say strategies, triggers, include asking open-ended questions. So, I usually use the example of something like, what would you like to eat? That's a really hard question to answer because the person with dementia has to think about, okay, what time of day is it? What meal is appropriate at this time of day? Okay, of all of those foods that are appropriate for that meal, which of those do I like and what do I want right now? That's way too much to think about. So we want to avoid asking those open-ended questions. Also asking abstract questions or providing too many choices can be triggers. Complex statements, multiple directions. Again, things like yelling or negative tone of voice or blaming the person with dementia. Even things like reasoning with them, trying to reason them into wearing a winter coat when it's cold out. Sometimes trying to reason with someone with dementia can actually increase or trigger a behavior as well. Okay, hope all of that is making sense. And then we also have the environment bubble. So we want to think about what's going on within the environment that triggers behavior. And this, I feel, is an undervalued aspect of dementia care. The environment plays such a significant role on behaviors and also in strategies, which we'll talk about later. But we want to make sure that we know what is going on within the environment that could potentially be causing a behavior. Things like noise, the television being on in the background or the radio, people talking, unsafe conditions in the home could potentially lead to challenging behaviors, different odors or smells. Maybe there's not enough going on in the environment to stimulate someone. There isn't really anything to engage with. There's no activity going on, or the opposite is, the environment's really cluttered and overwhelming. And so the person with dementia can't identify what objects they're supposed to use for that task. Also, we want to pay attention to things like the temperature, because that can impact if the person with dementia is too hot or too cold. And also the lighting, is it too bright? Is it too dim? Is there glare? All of those things are factors that we want to keep in mind. Okay. Any questions about the triadic model? I'm going to apply all of this shortly, but I want to make sure I address any questions if necessary. Okay, great. All right, so now we're going to take all of these bubbles from the triadic model and we're going to apply it. So I want you to think about this scenario. So in this case, Mr. Smith resists and argues when his wife asks him to take his medication. So again, I want to make sure that we're focusing on triggers or causes of behavior. So we're not going to jump into strategies quite yet. We want to set a really good foundation for why is this behavior happening. So this top bubble, the bluish bubble, this is the person with dementia. What's going on within them? So I want you all to try to think back and think, okay, I know we don't have a lot of context for this particular behavior, but I want you to just take a guess and put in the chat, what is going on within Mr. Smith that could potentially trigger his resistance to taking medication? I'll give you a minute to give some feedback, some potential triggers. And Allison, you can feel free to share if there's anything that comes into the chat.
So far we have a few people saying loss of control, sense of loss of control.
Absolutely.
Someone said dehydration. Maybe he has dry throat. He doesn't want to take the pills.
Absolutely. That's a great point.
Fear, mistrust. Another person says lack of trust.
Yes. Yeah, those are all fantastic answers. Well done, everyone. I like all of those answers. I just, put in some that I thought might be going on, but everything you all said was completely appropriate. So maybe he thinks he already took his medication. Again, sense of loss of control, what you all said, not having that trust. Absolutely. Those are all factors that could be going on within Mr. Smith that could be triggering his resistance. Okay, so now this kind of brownish bubble, this is the caregiver. So what do you think is going on within the caregiver? So what do you think maybe his wife did or said that could have triggered resistance?
Rushing.
Rushing, definitely.
Tone of voice.
Mm-hmm. Absolutely, tone of voice.
Poor tone of voice. Caregiver is bossy.
Yeah, yeah, absolutely.
Annoyance,
Mm-hmm.
impatience.
Absolutely, absolutely. And again, no judgment from my end. I know it's incredibly challenging to be a caregiver, but we do know that some things like that can trigger resistance or behavior. So again, I just put a couple in there, but all of the things you shared were very appropriate. So maybe she asked an open-ended question. Maybe she just said, did you take your medicine? Or can you take your medicine or something like that? So maybe she just made it really open-ended. And maybe she's trying to reason with him. Maybe she's trying to say like, you have to take this because your blood pressure's high. Or maybe she's saying, your memory isn't so good and you really need this pill for your memory. And maybe that's triggering some tension between the two of them. And that's exacerbating that resistance and leading to some of that arguing. Okay. And then the last bubble, this kind of like orange-ish color, yellow, I don't know, gold, I don't know what we want to call that. That's the environment bubble. So what do you all think is going on within the environment? Again, we have no context here, so we're just going to take guesses. What might be going on within the environment that is creating or triggering Mr. Smith's resistance to medication?
Okay, so far we have a disorganized environment. There's too much kind of noise input.
Absolutely.
Someone's also asking about the role of odors.
Absolutely.
Hoarding. Okay, so too much stuff around.
Great. Those are all great answers. So, an overstimulating or cluttered environment, fantastic. Maybe there are strong odors, that are distracting him from what he's supposed to do. That could absolutely be a factor. Again, these are just some that I came up with, but everything you all shared is very appropriate. So maybe it's noisy. Maybe the television's on in the background and he can't really concentrate on the task at hand. Maybe, the table is set up with his breakfast and lots of other items on the table. And so he's distracted by what he's supposed to do, and that triggers resistance as well. Excuse me, there could also be glare on the table, so he can't even really see his medication, which is exacerbating the resistance as well. So again, this is all kind of hypothetical because we don't have the specific details for this particular client, but I want you to really start thinking about what are triggers within each of these categories, because I do think it's really important, again, that we're thorough. That's going to help us when we come up with strategies, because we want to make sure we touch on all possible areas that we can. So I'm going to apply this to a couple more scenarios, and I'll just share what I have come up with. But again, I want you all to just think about this. So you don't have to put it in the chat this time if you don't want to. So we're going to talk about a scenario where, this Mr. Smith has been rummaging. He has been moving important items all over the home when his wife's at work. So a couple things that could be going on within Mr. Smith, he might be bored. He doesn't have anything else to do, and that's his activity of choice. He may have an unmet sensory need. And by that, I mean, when we think about senses, tactile sense, or sometimes in OT, we'll say like a proprioceptive sense, looking for input, right? Wanting something we can touch and feel and hold. And so he may have this unmet sensory need, and he is in what I would call a sensory seeking mode. We'll talk more about that in strategies later on today. He might also be trying to find a very specific item. So maybe he misplaced his wallet and therefore there's a lot of rummaging because he's trying to find out where he placed his wallet. And then also just wanting to feel productive. I have some clients who are rummaging because they want to feel as though they're helping. So they might be thinking that they're organizing their closet, but really they're just kind of moving items from one place to another over and over again. So those could all be things going on, again, within Mr. Smith that could be triggering rummaging. The caregiver here isn't present. So, they're not doing anything necessarily to trigger the rummaging, but maybe not being present, maybe not kind of setting the person up with activity could be a trigger for the rummaging. And then again, when we think about environment, so maybe some of these important items are really kept in an easy to access, easily accessible location. Maybe there aren't a ton of opportunities for things like exercise or other types of activity engagement. So again, all of these could potentially be triggers for Mr. Smith's rummaging. And then one more example using the triadic model. So Mr. Smith, I'm using resistance again, because I know resistance to bathing comes up all the time. So we're going to talk about that today. So Mr. Smith becomes resistant and yells when his wife asks him to take a shower. So again, what's going on within Mr. Smith? So again, that loss of sense of control that I talked about, absolutely a factor with resistance to bathing. I know I don't have that up there, but all of you got that spot on with resisting medication. So I want to make sure I pull that over here as well. So Mr. Smith might be cold. The water might be cold, the room might be cold. Again, that's environmental, but he himself is feeling cold because of the circumstances. He might also perceive the water itself or the water pressure as painful. He may feel an invasion of privacy, so he doesn't like disrobing in front of others. He might be confused about what to do. He doesn't necessarily know exactly what he's being asked, or he might be afraid. So maybe the threshold into the shower, stepping into a tub shower, maybe that's scary and he's afraid he's going to fall. Again, these are just a few hypotheticals. I'm not saying this is the case for every client who has resistance to bathing. I just want to give you some ideas. Okay, it could be that his wife asked an open-ended question. So again, maybe she said, did you take a shower today? Or can you shower? Maybe there's a lack of respect for privacy. So maybe, a paid caregiver has been working with this client for a while and, they just kind of go in and start going through the motions and just start to take Mr. Smith's clothing off without thinking about the fact that he is uncomfortable being, exposed in front of other people. Maybe the word shower is a trigger, right? So I like to ask people to break down and figure out exactly when does the resistance start? Is it when you say time to take a shower? If that's when the resistance starts, then the word shower is a factor here. The word shower is a potential trigger. So we really want to think about what are the specific details or circumstances surrounding your family member's resistance, because that's going to help us come up with strategies. So we want to pay attention to if words themselves are triggers. And then again, also maybe the caregiver was rushing. So maybe, Mr. Smith had to get to the day program on time. They only had a few minutes to get things done. And so she was trying to rush him to get a shower so they can make it to the day program on time. And then that last category, again, is the environment. So we want to think about temperature. When we get into strategies, I usually say, if I'm not sweating when I'm supporting a client during bathing, then it's not warm enough. So being too cold is a very, very common trigger for resistance to bathing. Again, also an overstimulating environment. So there's too much going on. Maybe the caregiver gave a whole lot of cues and instructions, and the person with dementia has there's the TV on in the background, and they're trying to process, TV noise, all these cues from the caregiver, plus the environment with the shower, it's all too much to handle. So an overstimulating environment. And then again, I have here unsafe. So maybe they're not feeling secure in the transition from, the bathroom into the shower. Maybe they feel like they're going to fall, and that could potentially trigger some of that resistance.
Okay. Rachel, we're getting a question. If you could clarify what you mean by open-ended questions.
Absolutely. So an open-ended question, I think about that as something that, doesn't have a concrete answer. So, I think about an open-ended question versus a question that has choices, so to me, an open-ended question, well, even I guess you could say that, do you want to shower, does have choices, yes or no. But I think about an open-ended question as being something like, what do you want to eat today? When do you want to shower? Even to me, saying something like, do you want to shower is not setting us up for a lot of success. So I try to avoid questions like that as well. But open-ended really meaning that, there really isn't one concrete response to that question. I also try to avoid yes or no questions, because from my experience, 9 times out of 10, the answer is going to be no. And again, I can go onto a little tangent about this at some point, but I feel as though the reason for that, again, has to do with that sense of loss of control. So if someone with dementia is presented with yes or no, if they say yes in response to a question, they might not be totally sure what they're agreeing to, right? If I say yes, I don't really know what's happening to me, what it is that I'm agreeing to, what the circumstances are. But if I say no, nothing changes. I maintain control, I'm safe, I stay here, right? And so if we ask a yes or no question, we're setting ourselves up to get a no in response. So I usually say I want to avoid yes or no questions. I also want to avoid open-ended questions, being questions that really don't have a specific answer that we're looking for. So open-ended versus a question with choices. I hope that helps clarify.
Thank you.
Thank you. Any other questions in the chat, Allison?
Not right now. No.
Okay. All right. Thank you. And thank you for that question. I think that's a really good point for me to clarify, especially because I'm lumping yes or no questions into open-ended. And then I also want to talk about, when we talk about triggers and causes, I also feel like it's important to just mention this ABC model. Some of you may have heard about the ABC model before. This is used in a variety of settings, not just in dementia care. But when we think about the ABC model, we think about the antecedent, or sometimes you'll hear the word activator. Really, that's all of the triggers that we've been talking about so far. So what is happening before the behavior occurs? Then the behavior, that's what we're trying to typically change. Sometimes there's a good behavior that we want to try to reinforce. And then the consequence. So the consequence is what's happening just after the behavior. How are we responding to the behavior? Because that can potentially make a behavior better or worse. So if I put that in context, again, we have the antecedent. So Mrs. Smith says, do you want to take a shower today? Mr. Smith becomes a little agitated. He says, no, I already took one. And then Mrs. Smith starts to kind of reason with Mr. Smith and says, no, you didn't. You haven't showered this entire week. So based on the consequence, we can assume that this response is actually then going to become its own activator or antecedent. So the consequence, the response, is going to make the behavior worse. Mr. Smith is now more agitated, and now they're yelling at each other and they're arguing, right? So we want to think about our response to a behavior and if our response is going to improve or exacerbate the behavior we're dealing with. Okay. And then you might ask me, Rachel, but how do we know what the triggers are? And again, that's where we have to do a little bit of detective work. So you all did a fabulous job at providing really wonderful guesses and input into what possible triggers might have been using the triadic model. We can also ask ourselves a few more questions, like who is around before the behavior happens, who's around during the behavior. I always say I like to really clearly define the behavior, because just saying aggression, my family member is aggressive, versus they push me when I try to help them take their shirt off. Having more detail, having a defined behavior is really going to help us when it comes to strategy. So we really want to be specific when defining our behavior. What would make the situation easier or better? So the other thing I like to talk to my clients about is, setting realistic expectations or goals for ourselves as well. So it might not be extremely realistic to completely eliminate a behavior, but can we reduce the frequency of the behavior? Can we reduce the intensity of the behavior? And would that make the situation more manageable? We also want to think about, again, what's happening before the behavior, that antecedent, but also where. Is there a particular room in the house that this behavior always occurs? Is it always happening outside of the home? Maybe someone says, oh, well, this behavior only happens at the day program, but it never happens at home, or vice versa. Okay, that's helpful. That tells us that there's something about the environment or the people in the environment that could be triggering that behavior. We also want to think about time of day. Is this behavior only happening in the morning or only happening at night? Is it associated with any other activity? So maybe they're only, becoming agitated when grandchildren come home after school in the afternoon. So if we can kind of pair the behavior with some other activity or event that's happening, that will help us as well. Again, how are we responding to the behavior? And then I made it really bold at the bottom. My favorite question to ask: is there ever a time where the behavior does not occur? If the answer to that is yes, then that's our biggest clue into what the triggers are. If there is a time where the behavior doesn't happen, then what we need to do is figure out what is different between when the behavior does happen and when the behavior doesn't happen. That's going to help us figure out what the true cause or true trigger of that behavior is. So I would highly recommend you all think about that as it applies to your own challenges or your own family member who may have behaviors. Think about, is there ever a time where they're not experiencing that behavior? Okay. And again, if I didn't kind of make this point clear in the beginning, I would love if you all, now that you've drawn that triadic model on a sheet in front of you, I would love if you think about how to apply this to your family member or the person for whom you're caring. Think about a behavior that you're handling or dealing with, or maybe not handling so well, and think about what are the triggers. What's going on within your family member? What might you be doing or saying? And what's going on with them in the environment? And use these guiding questions to help you figure out what triggers are causing this behavior. So try to make some of those notes as we go along. Okay. Any questions about the understanding triggers, identifying triggers?
We have a question about bathing. I'll read it. You might want to wait to address it until you do problem solving.
Okay. Thanks,
We're
Allison.
really struggling to get my dad to bathe. He insists all the time that he had just gotten one. He lives alone with my mom, and I am 2 hours away. When I go to visit, he will shower for me.
That is a great point. Thank you, Allison. So I think that might be a really good one to address in more detail when we come up with strategies. But I do think it's important to note here, the slight difference, right? So if a family member is participating in something like bathing with one family member, but not the other, I encourage family members to think about, what's the communication style? So is your tone of voice different than your mom? Are you using different phrases or different words than your mom's using? So I would really try to dig into the specifics of exactly how are you communicating a particular task to your family member. Again, maybe he has certain trigger words. Maybe you're using a slightly different word than your mom. So you want to try to make a note of all of those things. Sometimes the trigger is an actual person, but it's rare that that's the case, or I shouldn't say rare. I don't want to jump to that as our first option. So I usually like to tell people, first I want to think about, is communication style different? And then if we've established that communication style is absolutely the same, we're using the same words, we're using the same phrases, our tone of voice is the same, then maybe we'll say, okay, so maybe it's resistance with this one person, but we don't want to jump to that conclusion unless we've ruled out all other aspects of caregiver communication and management style first. I hope that helps. We get this a lot in the occupational therapy world. You'll hear like, oh, well, my family member will do it for you. And sometimes I think that that's absolutely true. But sometimes I also encourage people to think about, well, there are specific techniques that I'm using to encourage their participation. So I'm thinking about my communication style. I'm thinking about my tone of voice. And so those things carry a heavier weight than just being an outside person. Again, we'll get into more strategies in a few minutes. And I would love if any of you are comfortable sharing, just kind of very simply, if you think about something you're dealing with. So maybe just typing in the behavior and a trigger in the same box. So again, an example, resisting taking medication, trigger is loss of sense of control. So if any of you are willing to share some of the behaviors and triggers that you've identified so far today, that would be really helpful.
There's a few people typing, so we'll give them a second.
Okay, that sounds good. I know I really put everybody on the spot. I'll give you a minute to think through that if anybody would like to share.
Okay, so one behavior we have listed here is irritation.
Okay.
And then it says trigger is offering too many choices or an open-ended question.
Okay, great. So irritation, or sometimes we'll hear that be called agitation, maybe something like that. And offering maybe too many choices could potentially bring that on. Great example. Thank you for sharing.
We have another one, which is resisting stopping driving. And the trigger listed as sense of a loss of control.
Absolutely. Fantastic example. So resisting stopping driving, sense of loss of control as being a trigger. I think that that's spot on. Absolutely.
We have another one here that says sometimes gets rude when my friends are visiting me.
Okay. That's it. Sometimes, rude, socially inappropriate, or maybe even verbally aggressive when there are other people in the home. And there could be, again, a variety of triggers, but one of which could be overstimulated, overstimulated by the number of people in the home, keeping up with various conversations, that type of thing.
Okay,
Thank you for sharing.
More interesting ones. So the first one, this doesn't come with a trigger, but one says hiding everything. I know that that's very common.
Yes.
Bills, keys.
Yes, absolutely. So sometimes we'll call that like a hoarding type of behavior. That reminds me very much of my grandmother, who, if we would take her out for, a meal somewhere, she'd be like shoving silverware in her sleeves. I'm like, Mom, you can't take the forks with you. So yes, hiding important items. Oh, did I do that? I have okay. I had a funky thing come up on my screen. So absolutely, this idea of hoarding items. So again, I think that there's a control aspect there as well, right? Sense of loss, maybe in their childhood, they maybe didn't have access to a whole lot of items. Maybe they didn't have a lot of money, or there was insecurity growing up. And so they're reverting back to some of the behaviors to hide and keep some of those perceived valuable items close and safe. Absolutely. Great example.
I want to share one more, which is just an update to the question that was asked about showering. So this person has given me permission to share this, but they say,
okay.
My grandmother, so I guess the patient's mother, was not a nice person. She treated my father very badly growing up. As my mom is now the caregiver, he will reply to her, "You're just like my mother." So it sounds like the trigger then is similar to what you were just saying, his childhood memories of sort of being told what to do by someone who didn't speak to him very nicely.
Absolutely. Absolutely. And again, we are going to do our best to try to come up with some strategies, in kind of the second half of today. Sometimes it's not the easiest thing in the world, right? To just come up with a strategy that's going to fix a scenario. But I think having this insight and being able to better understand why our family member is reacting in a particular way can help us have a little bit, sometimes more patience, more empathy, more compassion if we understand why this is happening. So I think that that's such great input. Thank you for whoever gave Allison the permission to share that example. That's a fantastic, example of kind of pulling someone's childhood memories as well, because we know that as dementia progresses, many times people get some of their generations a little confused. So they might think that their mother or their wife is their mother or their child is their wife. And so if there's any sort of similarity, that could potentially trigger some resistance, agitation, frustration, those types of things. Yeah. Thank you, Allison. Okay, wonderful examples. I appreciate, Allison, you being able to read and share all of them for me. You're wonderful. You all have provided such great examples. I hope you're feeling good about the whole process of defining a behavior and thinking about triggers, because now we're going to start getting into strategies. Okay, so when we talk about strategies, I like to break it down into some different categories. So we have communication techniques, the environment, we want to adapt that, changing the task, and then maximizing activity engagement. So we're going to talk kind of generally about all four of these categories. I might go through some of this quickly because, again, then I'm going to try to apply this to some specific examples, and I'm going to do my best to leave some quality time for Q&A. Okay, so communication techniques. First thing I have on here is lowering the expectations, or in the Skills to Care program, we use the phrase relax the rules. So, if someone does something a little different, but it's not hurting anyone, we can relax the rules. An example of this is, if someone decides that they are going to wear their shirt inside out, and it's not unsafe, they're not even leaving the house that day, that would be something where I say, relax the rules, right? If it's going to cause a lot of frustration, resistance, agitation, and stress for both of you to promote the person switching their shirt to, the correct manner of wearing it, it's not worth it, right? That's one of those situations where we can say, relax the rules. Relax the rules also comes up with bathing quite often as well. I usually say, is my client happy, healthy, and safe? If they're happy, healthy, and safe, I'm happy. So we can apply that to bathing. Maybe the person doesn't need to bathe every single day. Maybe a sponge bath can be provided in between showers, or maybe a sponge bath in place of a shower is perfectly acceptable for that individual. So we want to think about what's realistic and be willing to change our expectations about what is perfect or right. We also want to talk slowly. I'm sure you've noticed that I'm not always the best at this one. So I often am a fast talker, so I have to kind of stop myself, slow things down. We want to maintain eye contact and look directly at the person with dementia and only provide one direction at a time. For example, I'm not going to say, Dad, go upstairs, go in the closet and get a towel out from the second shelf. Way too many instructions, right? Going upstairs, going to the closet and getting a towel out from the second shelf. He might remember to go upstairs. And then once he's up there, he's going to be confused about what to do. So we really want to work on providing just one direction at a time. And if we provide choices, I usually say no more than 2 choices. So I've often used one example that came up in a support group I was in one time where a woman shared with me, and I'm sorry if some of you may have heard this example before, but a woman shared with me that she was with her husband who had dementia, and she asked him, "Hun, what kind of ice cream do you want? Do you want chocolate, vanilla, or strawberry ice cream?" And then he said strawberry, and she got really frustrated and said, "Strawberry? You don't like strawberry ice cream, you like chocolate ice cream." And then he said, "No, I want strawberry ice cream." And then they got in an argument. If she were to kind of break that down, I say no more than 2 choices, but it's okay to just have one choice, right? Do you want ice cream or do you want chocolate ice cream? And again, if the person says yes to that, you could get them chocolate ice cream. But even preferable to that, if the person likes chocolate ice cream and that they like chocolate ice cream, no need to ask the question. You just go and get the chocolate ice cream and you hand them chocolate ice cream, right? So we can reduce the amount of choices that we're providing in order to promote engagement in a task. Okay. And then again, thinking about management style. So breaking down tasks. I think about this related to dressing a lot. Maybe it's too complex for the person to get themselves dressed 100% on their own. But maybe if we lay out just what they need for the first couple steps of dressing. So maybe we just lay out underwear, socks, and an undershirt. And then once they've done that, then we put out pants and a shirt. And then once they've done that, we put out a belt and shoes. So we can really break things down to help support engagement without the person accidentally maybe trying to put their shoes on before their socks or trying to put their shoes on before their pants, right? So we can help support the steps and the procedure that they follow by breaking it down. Okay. And again, when I think about pulling those items out, I'm not giving them just like an open closet of all these different clothes and they have to make a decision about what's appropriate for the weather or the activity that they're doing. Rather, I'm pulling items out for them and laying them maybe on the bed. That way it's less that they have to use their cognitive energy, if you will, to make decisions like what to wear. Okay. Again, we've talked about this concept of kind of open-ended or abstract questions. We also want to think about body language and tone of voice. So I know this is a hard one, especially when we're tired and when we're stressed, but our body language and tone of voice can have a really significant impact on the person with dementia. So thinking about the way in which we're saying something, does it convey respect? Are we saying this in a way that won't make them feel as though we're scolding them or trying to force them to do something? Also, are we standing there with our arms crossed, or are we relaxed and don't appear stressed and are going to set a calm environment and a calm tone for our family member? We want to try to avoid rushing, allowing plenty of time, not only for the person with dementia to respond, but also excuse me, I have hiccups from my lunch. We also want to make sure that we're allowing enough time for the actual activity. So again, we don't want to engage in something like dressing that might typically take a half an hour for our family member to do if we only have 15 minutes before we have to run out the door to get to the day program. That's going to create stress for everyone. And most likely it's going to take your family member even longer than their typical 30 minutes because they're feeling rushed. We do want to use plenty of words of encouragement. So, you're doing a great job, or something that I use very often is thank you. Thank you for your help. Thank you for supporting me. Even something like, a client where I would tap his foot to have him lift his foot so that I could put his shoe on. Thank you. Thank you for your help. Letting people know that they're appreciated goes a long way. So the more you can work in that type of thing with your family member, I think you'll find that that can be really helpful. Okay. A couple other communication strategies. So we do want to avoid telling the person with dementia in advance of visits, appointments, and other events. I know that this is a very, very hard one to do. I get a lot of pushback from caregivers about this strategy because it doesn't feel like something that makes sense, right? Well, I want my family member to know what's coming, or I'm trying to help them understand what we have on the agenda today, so I'm telling them. But what happens is this often triggers anxiety. This is one of the biggest triggers for anxiety and repeating that I have witnessed. So again, for example, I'll apply as much to my own grandmother as I can think of. So my grandmother, if someone were to say to her, Mom, we're coming to visit you on Tuesday, we'll be there, or even like, we'll be there for Thanksgiving, we'll see you on Thursday for Thanksgiving. Well, if we tell her a few days in advance, what would happen with my grandmama is she would be very anxious, right? She would ask all of the staff, where are my family members? When are they coming? I need to get ready. So she kept trying to go in her room and get dressed. She was all flustered because she knew Thanksgiving was coming up and she needed to make food. It just was creating a lot of unnecessary anxiety. So we learned the hard way that by telling her in advance of holidays or big events, that it was creating so much stress for her that we realized in future years that we needed to just show up. Right? We just showed up at the nursing home that she was at, happened to have a meal that we could enjoy with her. And that is how we could celebrate Thanksgiving in a way that promoted her quality of life. We weren't creating unnecessary stress, repeating anxiety by avoiding telling her in advance. So I know it doesn't always feel right, but it is the best thing that we can do for our family members. We also want to go along with their belief of what's true. This is another really tough one. So we don't want to reason with them. We don't want to rationalize or argue. We want to go along with their belief of what's true. So if someone has a distressing belief, we want to try to meet them where they're at. Even in situations where maybe they think that someone's stealing from them, right? We don't want to come in and say, no one's stealing from you, your purse is right there, because we all know that doesn't usually work. Instead, we're going to use this little catchphrase I have at the bottom: acknowledge, reassure, redirect. So for example, client once said to me, you stole my purse. My response is, I am so sorry that your purse is missing. I am so sorry. You could even say something like, I'm so sorry that you feel like I stole your purse, something like that. So I'm so sorry your purse is missing. We're going to see if we can get it back. We're going to try to find it and get it back to you. So reassuring them that you're trying to do the right thing, and then redirect them. So once we know that we've acknowledged the situation, we've reassured them, then we can redirect into a different conversation. So in the meantime, I want to show you a picture of my dog. That's usually my go-to, right? So if I know the client is interested in a particular whether it be dogs or whether it be, they used to be a nurse, talk about their nursing days, anything we can pull from to distract or redirect into a different conversation is what we want to do. Again, we can apply this to things, distressing beliefs, delusions, hallucinations, acknowledge what the person is saying, or even more importantly, acknowledge how they're feeling. So if someone says to me, I want to go home, the best thing that you can do is think about how are they feeling? What is the emotion that they are trying to convey, and respond to that. So in my mind, if someone says to me, I want to go home, what they're really saying to me is, I don't really feel totally safe, comfortable, secure. And so our response is going to be to try to provide comfort and security and safety. So saying things like, I know you want to go home. I'll be here with you all night, or I'm staying here with you. I love you. You're safe with me. Things that provide that security and safety. And then again, redirect. I hope that also makes sense for everyone as well. The only time where I would say I don't necessarily feed into the delusion or hallucination is if it's really negative. So if it's causing them a lot of distress, again, I still want to acknowledge how they're feeling. But for example, someone once told me a client of mine with dementia was seeing people on fire outside. I'm not going to say to them like, yes, people are on fire outside. That's not going to help the situation, right? But what I can do is acknowledge how they're feeling. Oh my gosh, that's so scary. You must be so scared. Everything's going to be okay. We're going to take care of it. You're safe with me. Things like that, right? Anything reassuring to provide them that comfort. Okay. And then the explaining and rationalizing, again, I kind of touched on this a bit earlier, but, I vividly remember a client who kept trying to wear a winter coat when it was like 100 degrees outside. And the husband kept trying to explain to his wife, it's not safe for you to wear the coat outside and you're going to get heat stroke and you can't wear this because of the temperature. But the reasoning and the rationalizing and the explaining, it wasn't working, right? She didn't believe him. She kept saying, it's fine. I know what I'm doing. So instead, we want to think about other strategies we can use. And I don't necessarily have a whole slide on this, I don't believe, but I do encourage people to think about how they can communicate with their family member outside of just words. So can you demonstrate for them what they need to do? So in this scenario, I asked the husband if I could borrow a winter coat from the jacket or from their closet. I put on a big winter coat and sat next to my client, chit-chatted with her for a few minutes. And then after a bit of time had passed, I said, oh man, I've gotten kind of warm. I'm going to take my coat off. Demonstrate for her what I'm doing. And then I can even say something to her like, oh, can I give you a hand with yours? Right? So we're not trying to reason her out of wearing the coat. We're demonstrating instead for her what it is that we would like for her to do. So I want to encourage you to think about how can you communicate outside of reasoning or rationalizing. And we'll apply that same type of strategy when we talk about strategies for resisting medication. I'll get to that in a bit. Again, thinking about, we have these different categories. We want to think about the environment. So we've talked about the idea that clutter can trigger behaviors. So we want to reduce clutter when possible, change the lighting as appropriate, change the temperature. That's really, really big when it comes to bathing and dressing, as being cold is a very common trigger for some of that resistance. And then again, eliminating harmful odors. So we had mentioned that earlier, but harmful odors can be things like urine and cleaning solutions. This is more common for my clients who are maybe in a more of a facility or community setting where maybe they're doing deep cleaning with lots of cleaning solution, or maybe they have a roommate with a strong urine smell that comes up a little bit more often than in the home. Okay, I have a couple pictures here for you. So on the right, the sink pictures, you can see that the top right is a little bit more of a cluttered sink, right? There's lots of different items out. So if someone needed to go and let's say wash their hands, it would be very easy for someone with dementia to accidentally use the wrong item, right? They might be using moisturizer instead of soap, or they might start to brush their teeth instead of wash their hands. So they're going to be a little bit more confused about what they're supposed to do when the sink looks like that. Versus in the bottom picture, it's going to be easier for the person to know to wash their hands if the sink is clear. Or if we need them to brush their teeth, having just the toothbrush and the toothpaste out on the counter will help promote that activity. On the left, this is a unique scenario. One of my clients did agree that we could share this picture, so I wanted to share it with all of you. This is not a perfect scenario by any means, and there's a few trip hazards, which I won't get into every single aspect of that at the moment, but this was a really unique scenario where we had to figure out bathing. So this was a client who they only had a bathroom on the second floor, and the client was becoming very aggressive when he needed physical support going from the first floor to the second floor. And so we had to be creative and figure out, okay, how are we going to promote him getting thoroughly clean, but now we have to do it on the first floor. We don't have the funds for total remodel. So again, this is not perfect by any means, but that's life, right? We make the best with what we have. So for this particular client, we ended up connecting a handheld shower head to the kitchen sink. And that way he can have the hot water. She had the laundry in the next room. So she had lots of warm towels getting, fluffed up and ready to cover this gentleman while he was sitting on the shower chair. We kept him fully covered, which again, I'll talk about this in more detail as we talk about specific strategies for bathing, but we kept him fully covered unless we were washing that one particular area of his body. For this gentleman, this scenario actually helped reduce his aggression because his aggression was triggered by needing the physical support ascending the stairs. So if we could eliminate that aspect of needing the physical support or assistance with getting up the stairs, he was in a calmer place. We could still get him clean. And again, happy, healthy, and safe, right? So we could still meet those objectives. Again, some of these towels are trip hazard. I wasn't thrilled about all of the towels being down where they were, but the wife was really concerned about any potential flooding. I understand. Also, the middle of the kitchen is not somewhere where most people would feel comfortable getting bathed. So we want to keep that in mind as well, that somebody might feel more resistant in a scenario like this. So this is where being really particular about what are the triggers for that individual is so important, because strategies that work for one client or one family member with dementia will not necessarily work for someone else. Okay. Couple other examples of environment. So I often show some pictures like this just to kind of give you an idea of what different levels of clutter and also levels of glare look like. So top left, that's going to be a scenario where if you ask someone to sit down and eat or take medication, it's going to be really easy to get distracted, right? There's a lot going on that table. The right-hand picture, I really like that setup other than the glare. There's some pretty significant glare on the table that might have an impact on the person with dementia being able to see their food, see their medicine, or see whatever activity they're doing at the table. Bottom left, that's a little bit of a better situation. There's a pretty plain colored tablecloth. Again, there's not a ton of contrast there between maybe the table and the floor and the chairs, but at least we're dealing with a plain surface to put the activity on top of. Okay. Some other examples of my clients' homes. So people who have really decluttered to promote engagement. So this is someone where, she needed her husband to engage in brushing his teeth. Of course, it can be easy to mix up something like the lotion and the toothpaste. So we might even just slip that moisturizer under the sink so that the only thing on the sink is the toothbrush and toothpaste to promote engagement. Again, simplifying the closet. So, removing any clothes that aren't environmentally appropriate or appropriate for that temperature or climate at that time of year. These are just some examples of some, safety hazards, but then also some strategies to promote safety. So if someone has a behavior that is triggered by fear of falling, we can think about things like grab bars, handles, raised toilet seats. Sometimes I have clients that have a difficult time with sitting on the toilet because they're so afraid of falling when it comes to what we would call a stand to sit transfer. So just the aspect of sitting back on the toilet can cause so much fear. But if we have a raised toilet seat with handles, like on the bottom right, it could help decrease some of that fear because they don't have to sit so low. They can also feel the handles behind them to give them some security. So again, if we have fear as a trigger for behavior, we might consider some of these supports. Changing the environment, so securing hazardous objects, keeping them out of sight. Again, I apologize if you've heard this example before, but I always think about one client I had where she was using toilet bowl cleaner as shampoo. And this scenario really happened just because the toilet bowl cleaner was stored on the edge of the tub. And so when the individual with dementia was in the shower, she wasn't thinking like, oh, this bottle shampoo, oh, this is toilet bowl cleaner. She was just grabbing a bottle, squirting it into her hands and rubbing it in. So something as simple as removing those hazardous items and storing them out of sight or locked up can help. Also have here some visual cues. So these are things like stop signs, labeling drawers, things like socks with a little picture to help promote not only the socks going in that drawer, but also when the individual has to get dressed, that they might be able to more easily identify where that item is. Okay, before I get into changing the task, are there any questions about communication strategies or environmental adaptations?
We have 2 questions about sort of people's versions of reality that might be helpful. I'm going to read both of them.
Absolutely. Okay.
One is about going along with the person's belief that is true. My mom thinks that one of her doctors said she has a low IQ. I was at the appointment and this was not said. Shouldn't I correct her? And then the second question is also, my mother thinks her mother is still alive and that she sees her. What do we say to her as far as acknowledgement?
Okay. I might have you repeat that second one in just a minute, Allison, if you don't mind. I'm going to start with the first one. So in a situation like that where, your mom thinks that the doctor said she has a low IQ, I understand where you're coming from. And of course you want to say like, no, mom, no one said that. Of course you're smart. No one thinks you have a low IQ. My guess is that even if you say that, she probably isn't totally believing it. She still feels as though she heard someone say that she has a low IQ. And so in that scenario, I think that it's still appropriate to acknowledge, reassure, and redirect. So it's still appropriate to acknowledge how she feels, oh my gosh, mom, that would have made me upset. You must feel upset. I would have been upset if I thought someone told me I had a low IQ. So really kind of relating to her on emotional and an emotional level. So letting her know that you hear her and that, you would be upset too if that were the scenario. And then reassuring her, mom, I know that you are incredibly smart. I know you have a high IQ. Your family knows that you're smart and have a high IQ. So letting her know that reassurance that, you're not necessarily saying like the doctor thinks you have a high IQ, but letting her know that her family and the people she loves are there to support her and they think she's smart and loved, and then redirect her into a new conversation. I think that that's probably the most appropriate in that scenario. Of course, there are exceptions to everything. If you say to your mom, the doctor didn't say that you have a low IQ, and your mom says, oh, okay, great. Of course, that if that works for your mom, I'm all for it. But more often than not, somebody isn't going to believe you if you go against her belief of what's true. I hope that helps. And then Allison, I'm sorry, can you just remind me of that second example?
Yeah, similar example, different situation. So my mother thinks her mother is still alive and that she can see her. What's an example of what they can say to her as a form of like a validation or acknowledgement?
Great question. So this is another one that comes up pretty often, right? When somebody thinks that their mom is still alive. I actually have, I think, 2 or 3 clients currently on my caseload where that is happening. So this comes up pretty often. So one thing that we want to avoid is trying to reason with our mom that her mom has passed, right? So what we don't want to do is put your family member through that same grief, loss, and sadness over and over and over again. So we don't want to try to convince her that her mom has passed. I have one client right now where, she has been trying to show her mom the gravesite and show her, yes, you've been to the funeral. And what that does is just create a little bit more agitation, sadness, and some tension between the two of them. So we want to try to avoid that. Instead, I would recommend, first I would ask, is it harmful? Is it bad that she thinks she saw her mom, or did it provide her with comfort? If it didn't cause any harm to her, I would just let it go. I think about, again, my great aunt Doris. She would occasionally talk about having breakfast with her deceased husband. I had one extended family member who would try to say to her, well, no, you didn't. He passed away. And then my aunt would start bawling. What do you mean he died? And that would create a lot of stress. What we ended up learning was if we just said, oh, you enjoyed breakfast with Uncle Jack, that's great. Right? It doesn't even have to be a big scenario. If the belief or delusion, if you will, or hallucination, if it's not causing harm, I recommend just letting it go. If for some reason it's causing some stress. So for example, with one of my clients, the client is following up with, I saw my mom earlier, but has anyone checked on her? Like she hasn't come home yet. And I don't know where she is. And so there's anxiety around that belief. Then I would recommend, again, trying to support that emotion. So, mom is safe. We're here with you. We're checking on her. You can even say things like, I'm sure she'll be home soon. I use a lot of phrases that end with soon because there's no kind of concrete end to when soon is. So saying something like she'll be home soon can give her that immediate comfort and security that she needs to relax in the moment so that we can then redirect her into another task. I hope that helps answer that question. Thank you, Allison. Anything else we should address now?
Yeah, there's just one more question that I think a lot of people would benefit from hearing. So very briefly, my mom would benefit from us helping with her selecting clothes, laying them out for her, as you had discussed, Rachel. However, she's not ready to give up that level of independence and is very proud of still being able to, in quotes, take care of herself. How can we transition to this with less resistance? So someone maybe in a little bit of an earlier stage.
That is a really good question and not an extremely easy one to answer because some of it will depend on this particular individual. But I appreciate this question because I think it is really important to work through this. One thing that I recommend is, if there are times, again, this is going to feel sneaky and that's not what I intend. It's all about how can I support the person with dementia without creating additional stress. Right. And so one thing I would recommend is when mom's not home or not in her room, if there's a way to at least reduce the amount of clothing that she has available. So I would say kind of starting with reducing the volume of clothing. That's a good place to kind of lay some groundwork because then that way, if she is still choosing her items, still choosing her clothing, she has less to choose from, which will it's more likely that she'll be successful in a scenario like that, right? So I would say usually we want to start like at a place where we just reduce volume. Then I would say we can probably ease into adding some little labels on her dresser. Again, she might not be thrilled with this, but that would be something that, again, I would recommend we do when mom's maybe not home. And then when we ease into actually laying the clothes out, I would, again, recommend that we're not doing this in front of her. So maybe while she's in the shower, we pick out an outfit and we lay it, on the bed, or if she has a chair that she usually dresses from in her bedroom, lay it there. So it's setting her up in a way that she might engage with the environment, but it doesn't necessarily trigger that sense of loss of control because she's not seeing us implement that strategy. So if it's possible to kind of set up the environment without your mom seeing you set up the environment, I think that that's the best chance for success. I hope that answers that question for now. Okay, thanks, Allison. Anything else we should address before I get into our other two categories?
No, I think let's full steam ahead.
Okay, sounds good. All right, so we have two more categories of strategies. This is changing the task, and then we'll get into activity engagement. So changing the task, we already talked about some of this, right? Routine, time, relaxing the rules, setting out items in advance, and reducing complexity. So the task itself can be broken down into easier parts. I even think about this when it comes to, let's say, like washing dishes, right? Maybe our family member likes to engage in washing dishes, but maybe that's too complex. So maybe we're doing all of the parts of washing the dishes and they're just drying. And then somebody else is putting away, right? So thinking about what are all of the different steps that are part of that task and how can we take over some parts, but also allow the person with dementia to engage in other aspects so that they still feel as though they're participating. Okay. And then activity engagement. So activity engagement, most of you know I could talk for hours just about activity engagement, so I'm going to keep it as brief as I can. Activity engagement makes me excited. So I always say, all of us as humans, we all have an innate desire to participate in the world. Doesn't matter if we have dementia or we don't. So when we think about participating, we want to think about capitalizing on lifelong social roles and interests. So what did your family member used to do? Were they a homemaker? Did they work in an office setting? Were they, I'm trying to think, security guard, construction worker? Those are some examples of my clients' past jobs where we could pull from that and create activities that supported what they enjoyed. I always say, again, relax the rules. So the purpose is about engagement. It's not about the end product. So if mom is working on knitting a scarf, I do not care if the scarf is finished or if it looks like a scarf or if it looks like something out of this world. If she's engaging and she's enjoying the activity, that's what we're going for. Of course, we want to keep safety in mind. So you don't want to set someone up with an activity that could potentially put them at risk. And then when we come out with activity, we want something that's, we want it to be repetitive and we want it to be familiar. So I won't get into all of the different levels of cognition in this presentation today, but as someone progresses, they will be more likely to engage in a task if it's one step and repetitive in nature. Meaning something like a puzzle might be too complex, but taking the puzzle pieces out of the box is something that they can do, or putting the puzzle pieces back in the box is something they can do. So we can always think about ways to break down a task to allow someone to engage. We want to have this established routine and try to work activities into that established routine. And a lot of times we use something like an activity box. So this is really just to make your life easier. So when you're, stressed or when your family member's agitated and needs to be redirected, that's not the time for you to be thinking of a creative activity or solution. So instead, if we have a little bit of time and can create an activity box that we can just pull items out as needed. So we can pull out a photo album. we can pull out a simple jigsaw puzzle or word search or knitting supplies, or we know that our family member will sort coins, so we have that all in this basket ready to go. So thinking about how we can set that up, so if there is a behavior that we need to redirect, we can just easily pull from that basket. This is just a list of some activity examples. The Alzheimer's Association also has a list of 101 activities you can do with someone with dementia. I usually have my clients start with that. If they're really struggling with what activities are we going to use, I always say, let's start with what did they used to do for work or for fun? And then also glance at that list and pick 5 out of 101. We can usually come up with at least 5. So those are some good places to start. Okay, few examples, and I promise I'm going to kind of connect all the dots soon. So some examples on the left, this is something called a twiddle muff. So this is, again, somebody who's very sensory oriented in nature, sensory seeking clients. Oftentimes, not all the time, but oftentimes people who are prone to rummaging also may fall into, again, kind of a sensory seeking category. And so when we come up with activities, we want to think about matching that need. I'll give more examples about rummaging in a moment, but this is one sensory-based activity. So this is someone who can engage by just kind of like touching and feeling the different items on this twiddle muff. They make a variety of different things like this, like an apron, a mat, blankets, things like that. On the right is one of my clients years ago who she used to be an artist. The husband would say to me, oh no, she doesn't do that anymore. But really she just needed a little support to get set up, right? So yes, she wasn't able to initiate. So she wasn't able, if you asked her if she wanted to paint, she would say no. And she wasn't able to pull the items out on her own. But once we set her up with a canvas and got the paints out and gave her a paintbrush, she engaged for, I think it was 45 minutes while I talked to the husband behind, in the next room. And at the 45 minutes, I had to leave, but she was still more than happy to continue to engage. So my point with that example is, don't make the assumption that just because your family member says no, or just because they haven't initiated or started the activity, that it's a loss. It might just be that they need someone to help them set it up. Okay. And when I talk about downgrading tasks or making things easier, I like to use this type of example. So if someone says to me like, oh, my family member can't do a puzzle, I like to try to figure out why, right? Maybe it's a little too complex. So the example on the upper right, there's not a lot of color contrast there. There's a lot of pieces. They're a little bit smaller. Versus there's the one in the middle would be the horses. And then the easier of the options would be the flowers. So they're thicker pieces, brighter colors, better contrast. So sometimes it's a matter of just downgrading or making the task or activity easier. Okay, now we're going to pull it all together. So before I do that, Allison, are there any questions about changing the task or activity engagement?
No, it doesn't look like it. A few more questions about driving, so we definitely want to make sure to get to that.
Okay, that sounds good. We'll try to pull when I'm going to pull it together with some of the examples we used earlier. And then we're going to try to make sure when we do some open questions that we talk about driving. Okay, thank you, Allison. All right, so earlier we had the example of Mr. Smith who was resisting medication. And so all on the left are all of the triggers that we had brainstormed. Well, not all of them, because you all had some additional great examples, but some of the triggers that we identified to resisting medication were things like believing he already took his medication. He has a sense of loss of control. The caregiver maybe asked an open-ended question or tried to reason with Mr. Smith. Maybe the caregiver used the word medicine, and maybe the word medicine was a trigger. Maybe the environment was noisy, or there were other items on the table to distract, or there was glare on the table. So if we know those triggers, now we want to implement our strategies, and our strategies should consider what the triggers are, right? So if he believes he already took his medication, one possible strategy, we're not going to try to reason with him, right? So one thing that we could try is something as simple as we walk away and we come back in a few minutes and we try again. You'd be surprised how often this simple type of strategy can be effective. Sense of loss of control. Something that I find can be really, really helpful is joining in the activity. So the person with dementia doesn't feel like it's just them that's engaging. So I will recommend to caregivers, try to take your medicine at the same time. Or if you don't have your own medicine, take a vitamin or take like a little bit of food or something that looks like medicine. So you can say medicine for you, medicine for me. And then again, demonstrate for them. So you put the pills in your mouth and take a sip. So you're demonstrating for them what you want them to do. Again, we're avoiding the reasoning and explaining because that's usually not going to help our case. Sometimes, again, if the word medicine is the trigger, call them vitamins, right? Time to take your vitamins. Some people will be really receptive to a simple communication strategy like that, where we just reframe it. Something else we can try is calling the pharmacist. So talking to the pharmacist, is there a way that are we able to crush this medication and put it in food? Is there maybe a liquid version available that would be easier for them to take and they'd be less resistant? So talking to the pharmacist about what other options are available for that medication can be really helpful. We also want to think about the environmental strategies. So reducing environmental distractions, turning off the TV, removing other items from the table, and then reducing glare with use of either placemat or a tablecloth. I think sometimes when it comes to resisting medication, sometimes as simple as, we put the medication on the table, told our family member to take it and walked away. But the family member with dementia really needs a little extra help and support. So maybe you have to physically put the medication in their hand, or maybe you even have to put it in their mouth, right? But again, being able to demonstrate for them is going to help. I find that when it comes to resisting taking medication and resisting taking a drink of water, the whole concept of doing it together is one of my best most effective strategies. So for those clients, I'll walk in, I'll pretend to put medication in my mouth. I'll, take water. A lot of times I'll try to make it lighthearted. So I'll say something like cheers and then take a sip. So showing them that, it's not just you. Again, I think that takes away from that sense of loss of control. Again, it works with fluid as well. So if I have clients who are resisting drinking, if I just say, oh, juice for you, juice for me, cheers, and then take a sip, it's not kind of putting the pressure on that individual to say, you need to drink, you need to take your medicine. It's a collective activity that we can do together. I hope that gives some concrete strategies that you all can use for resisting medication. I'm going to talk through our two other examples from earlier, and then I'll make sure we have lots of time for questions. Okay, so triggers for rummaging. We talked about the person with dementia being bored, having an unmet sensory need. Maybe they're trying to find a specific item like their wallet. Maybe they're trying to feel productive. We talked about somebody thinking that they're, organizing their closet. It could also be that, they don't have any other objects for stimulation or other activities. Important items are being kept in easily accessible locations. And we also might not have a ton of opportunities for other forms of exercise or activity engagement. So this can be, when it comes to rummaging, I usually say that rummaging is one of the better behaviors to have. And when I say better, I mean rummaging in and of itself is an activity, right? So your family member is attempting to engage themselves in activity. So we just figure out how can we adapt the rummaging in a way that's not going to disrupt your life and not going to disrupt, the way that you need to function with your items being in place, but can still meet their needs. So we can do things like providing opportunities for rummaging, but in a more controlled environment. I have an example of that on the next slide. Also increasing other forms of activity engagement. So if you know that they are willing to engage in some other activities or like to engage in other activities, of course, we can set them up and try to promote that type of activity engagement. And then some strategies like putting locks or labels or signs on areas of the home that we don't want the person to rummage in. And then increasing physical activity can often help reduce rummaging behaviors as well. But I do want to give some examples. So these are a few of my clients who had some rummaging tendencies. Again, all pictures are shared with permission. My client on the left, she was someone who, again, this is kind of similar to that twiddle muff. This is an apron or a lap pad with some different items that she could kind of fidget with. So she was someone who, she was kind of like moving papers all over the house. So really, again, a sensory seeking type of behavior, but she was thrilled to be able to engage in something like this lap pad. So this kept her busy for honestly like hours on end. She would sit and engage in this, of course, with like little breaks. So really thrilled about the success of this type of activity for that client. And then the client on the right, he was someone who also was rummaging, maybe not quite as, he didn't have dementia that was quite as progressed as the client on the left, but we still wanted to set him up with opportunities for rummaging in a meaningful way. So he was someone who really enjoyed fly fishing. So we made him some fly fishing rummaging boxes. So we created, big kind of like Tupperware boxes or plastic bins with various meaningful items for him. So fly fishing materials. So this was like, I didn't know much about fly fishing before working with this client, but these are some of the feathers and materials that he would use to make the flies. He also had a whole book of great pictures of different flies. And different fish as well. So we put the book in there. He had actual flies that he had made. Of course, that was a little dangerous because of the sharp hooks. So what we did is put them in a clear container and just tape the edges so he couldn't open it, but he could still look at all of the flies he had created while still being safe. So thinking about creating like themed rummage boxes can be really helpful. Are there certain items that your family member typically rummages? Is there a way that you can set them up to rummage those items in a way that will still be good activity for them, but won't completely disrupt your lifestyle or routine? That's what I would encourage you to do. So I hope that that helps for some rummaging questions. And then one of our most common resisting bathing. So again, I want to reiterate that not every client is the same. So not all strategies that work for one client will work for another, but I'm going to give you some of the strategies that work most often. So again, we determined that some of the triggers to resisting bathing were things like feeling cold, perceiving the water or pressure as painful, invasion of privacy, confusion about what they're being asked to do, fearful related to the transition into the shower. The caregiver may be asking open-ended questions or not respecting privacy, rushing, the word shower, too cold, overstimulating, and unsafe environment. Okay, so again, we have our framework for how are we going to develop strategies. We want to build them off of the triggers. So warm, we want to create a warm environment. Bathing, I know I said this earlier, but I will reiterate, I usually say to my caregivers, if I'm not sweating, it's not warm enough, right? So if I'm doing a shower successfully with somebody with dementia, I'm usually drenched in sweat afterwards. It's nice and toasty warm. Sometimes we can do that by using like a little heater in the bathroom beforehand. I usually, again, for safety, recommend that you remove that during the shower, but it's okay to heat it up beforehand. Sometimes people will run the shower before their family member gets in, make it nice and hot and steamy. Maybe have towels running in the dryer so they're nice and warm and fluffed up and ready for your family member. So anything we can do to keep it warm will help. We can also do things like using a handheld shower or maybe even a sponge bath. So again, if the water coming down from the shower head is perceived as painful, using a handheld shower head will help us just direct that water to one particular area of their body at a time. So again, we can use those towels, keep them all wrapped up and warm, and then only remove the towels for the area of their body that we're washing at one particular time. Again, that's if a client needs that physical assistance for that aspect of care. We can use grab bars and shower chairs to promote safety if their resistance is related to safety. We don't want to assume that our family member knows exactly what to do. So setting up the environment to support them is really helpful. Allowing enough time for the bathing routine, so we don't want to rush. And again, avoiding trigger words. So if they're resistant after the word shower, then we're not going to say the word shower. Instead, we can do something like, let's take a walk, or come with me. And we just happen to end up in the bathroom where the water is running and it's nice and warm and steamy, right? And the environment might tell them what to do. So it's kind of like power of suggestion, right? We want to set the environment up so the environment is telling our family member what to do, not us. That's going to help reduce that sense of loss of control. Of course, reducing any sort of background noise like television noise or radio, things like that. And we want to make sure when it comes to bathing that we're also allowing our family members some downtime after bathing. So again, this is something that requires a lot of energy for both the caregiver and the person with dementia. So not rushing right from bathing into something else can be helpful. Some other examples of clients I've had where bathing's an issue. Again, we want to think about the environment being set up. So we want to avoid the word shower. For some other clients, the biggest trigger is being cold. So, or their, lack of privacy. So we've done things where we've actually like wrapped warm towels around them under their nightgown or under their baggy shirt. And then that way, when we remove their shirt or remove their nightgown, they're still covered and they're still warm because they have a towel around them. It doesn't matter if the towel goes in the shower with them, right? So we want to think about, for our particular family member or client, what is the trigger for their resistance? Because again, it's not going to be the same for everyone. Okay. Whew. I hope that all makes sense, everyone. I hope you now feel like you can brainstorm some strategies as it relates to the specific triggers you've identified for your family member or client. And a couple points I want to make before we open it up for questions and we address some driving questions. When you try strategies, it's okay to try one or multiple at a time, but I usually recommend people try strategies for at least 1 to 2 weeks before we completely write it off. Of course, if a strategy makes the behavior worse, you can stop it immediately. I'm not going to force you to keep trying a strategy that's not helping or that's making something worse. But if you don't perceive it's doing anything, I would say continue to try it for a couple weeks before you write it off. When you found an effective strategy, I would highly recommend sharing that with all members of the care team because consistency is very important. And then you can also do something like keep a record or a journal of the strategies that you've used so that you can track some subtle changes. A journal can also be really helpful when it comes to identifying triggers as well, if you're having some trouble with that. Okay, I hope that helps answer some questions that all of you have, but I know we want to still talk about driving. So Allison, if you don't mind, can you give me some maybe examples of some of the questions that are coming up around driving?
Not too many specific questions other than how do I explain to someone that they can't drive anymore? And we have a few other questions in here as well. I know we're sort of running short on time now.
Okay, that's fine. So I think driving, again, is another extremely tricky scenario because it really does depend on that particular individual's cognitive functioning. So if someone, has a cognitive level that is impaired enough where we can use some more creative strategies and they won't necessarily be as aware, we want to try to do that. So for many of my clients, I recommend not explaining to them necessarily that they can't drive, because again, it turns into a major agitated episode where if they don't have the capability or capacity for understanding why they can't drive, then there's really not going to be a resolution to that. Instead, I recommend some more creative strategies, things like using now I'm going to forget the name, bar across the steering wheel, oh my goodness, we can't use it. It's been locked, the steering wheel's been locked, or, the battery's been taken out. Parking the car somewhere that's not in front of our family member's house so that they're not seeing it on a regular basis. Doing things, again, a little bit more creative where we're saying like, oh, the car's in the shop for repairs, and then the car just doesn't happen to return, right? But if they ask, we can continue to say things like, it might be ready soon. So we can use more creative strategies to remove the car from their access without necessarily having a concrete conversation about not being able to drive. Clients who are maybe don't have as significant a cognitive impairment, sometimes we as healthcare providers will have a conversation with the person with dementia. Again, it's really going to depend on their ability to reason and understand. So once in a while, if someone is at a stage where that's appropriate, I would say involve a healthcare professional, right? Talk to your doctor, talk to if there is an OT on the case, and see if they can support you in this conversation. So it's not just coming from you, but rather it's coming from a medical professional. And if that medical professional can provide, a letter or something in writing, that may also help the scenario. Again, some of that's going to depend exactly on where they fall cognitively. Allison, do you have anything you'd like to add to that conversation or any other strategies?
Just that if the person you're caring for is at the Penn Memory Center, we can help with that. I will also say we've gotten some clarification. We're talking about mild stage dementia or mild stage cognitive impairment.
Mm-hmm.
All I would say to add to that is that at a certain point, this might be a situation where there's not a creative way around it. Sometimes we run into obstacles like this, and a boundary has to be set. And in that case, I would say work with someone to support you as the caregiver so that you have the capacity to acknowledge this person's grief and loss over their loss of independence or driving while still holding the boundary. So saying, I'm sorry that you can't drive right now. You're allowed to be, as angry, disappointed, frustrated as you want, but there's nothing we can do to change this. Sometimes we just have to get to that point, and as long as you can do it in an empathic way, that's probably the key.
Yeah, thank you, Allison. I think that's such a phenomenal point, and one that we can use for more than just driving, right? Being on the same team as the person with dementia, letting them know that you hear them and that, they're frustrated and you're frustrated with them. Sometimes that can make the biggest difference because they don't feel like it's you versus them. It's the two of you in this together. So I think that that's a really great point. Thank you, Allison. That's great. Any other questions? Yeah.
Also gotten a question about impulsivity, specifically impulsive eating of like candy, sweets, junk food.
Yes, that is another behavior that comes up, fairly often as well, impulsive eating. So this is one where, again, I would recommend using environmental modification as much as possible. So by that, I mean trying to hide or remove, or maybe even lock up the items that you feel your family member is eating obsessively, but you can leave items out when it's appropriate. For example, I have a client right now who's known for eating like the entire bunch of bananas the second it makes it in the door, right? And I mean, that's not like the worst snack in the world, but he doesn't really need to eat like 8 bananas in a sitting, right? So instead, what we've done is we hide the bunch of bananas and the family will just put out a banana on the counter in the morning and then maybe another one in the evening. So they're kind of adjusting and providing just the snacks appropriate for that time. So really, again, trying to hide and lock. And another client who was known for drinking all of the milk and eating all of the ice cream. And while we did try some strategies like hiding those items at the back of the refrigerator, she was really, really able to weed through all the items in the refrigerator and find that milk and ice cream. So the family in this case actually was lucky enough to have a separate fridge in their garage that we just put all of the milk and ice cream in there with a little padlock. And honestly, the grandchildren thought it was the coolest thing in the world that they had like the lock that would open up to get their milk. So sometimes we can do something like that. Of course, I know that's not our first choice, but if we need to, we can implement something like a lock. Great. Any other questions?
I think we probably have time for one more, if you're okay with that.
Of course, that's fabulous.
Okay, so I've gotten 2 questions about, I'm going to call it shadowing.
Okay.
So sort of having, if you are the caregiver, having the person you're caring for just on you all the time, following you everywhere you go. You can't even get privacy to go to the bathroom.
Great. Another great example of something that comes up often as well. And I give you all so much credit because that's exhausting, right? I mean, all of these are exhausting in their own way, but I think having somebody who follows you even into, the shower, in the bathroom, or while you're sleeping, knock, knock, are you in there? Are you sleeping? It's a lot. So a couple things that we can try for something like this. One is activity engagement. So again, anything we can do that I call setup activities. So it might be that you have to sit with your family member and get them started in an activity. And then that might give you a couple minutes that you're able to walk away. Again, when we think about triggers, security, right? You are their security blanket. So being around you gives them a sense of peace and security. So it might be that you set your family member up with an activity and you're still sitting in the room, but across the room doing your own thing. So it might be that they just need you in their visual field. And then some other things that we could try as well, if your family member is able to read or see, or even hear, we could try something like that. So we've done some visual cues. So put like a big sign right in front of them. If let's say they're sitting, in a chair in the living room, big sign right on the coffee table or on the wall across from them that says, Mom, I'm home, I'm upstairs, I love you. Bless you, Allison. So I think that, again, we want to think about our strategies reflecting the trigger. So if our trigger is sense of security, by providing them with a visual cue, we could potentially give them a little bit of that security back. Mom, I'm safe, you're safe, I'm upstairs, something really simple. So Mom, I'm upstairs, I love you, and then sign your name. So you can provide those types of things, again, right in the visual fields. They can't miss it. And that might be enough to at least reduce the shadowing behavior. And again, some of my clients, we've used things like auditory cues. That's a little bit harder to do, but where we like play something on repeat, that's your voice that says like, you're safe, I'm home, as a way to try to, again, meet that emotional need to provide them with that sense of security. But again, that's a little bit trickier to implement. Thinking about the triggers and thinking how our strategies can reflect the triggers that we identified. Hopefully that answers that question as well.
It looks like that's it in the question box.
Okay, perfect. I hope everyone feels like they can walk away with something. I'm sure that there are a few lingering questions. If I can do anything to support you, of course, my contact information there is there. You can feel free to reach out to me. I'll do my best to support you if I can. But hopefully you all feel like you can walk away with some sort of concrete strategy that you can try. Thank you so much for having me.
Rachel, thank you for being here. The chat right now, it's not that they're not questions, they're just all effusive thanks and gratitude for your time today. And I share that sentiment. People are saying how helpful this is. They feel like they feel more prepared, more sturdy, more confident. So thank you so, so much for being here with us today. I also want to reassure everyone that this is being recorded. We'll send the recording out. Rachel, I'm hopeful if you're okay with this, that we can send the slides out as well.
Oh, absolutely.
Great. Okay. So we'll send all of that out to everyone who's registered. And I want to make one more brief announcement, which is that this is a lecture series. Our next series is on Thursday, November 4th, also from 12 to 2. We'll be hosting Andrew Morton from Time Slips. And he will be talking about how to invite friends and family, basically teaching friends and family into creative engagement with older adults. So going off of Rachel's activity engagement, if you're feeling stuck trying to figure out what that could possibly look like or how to do that in a creative way, I think Andrew will sort of pick up that baton and then expand on that. And you can register for that on our website as well. All right, everyone. Thank you so much. Thanks again.
Thank you, Allison. Thank you, Penn Memory Center, for having me.
Have a good rest of your afternoon, everyone.